Okay, welcome back everybody. I know it's been a rushed lunch hour, but thank you for being back on time. Order panel, please. Okay, this is our penultimate session, and this is where we hear some of the latest research progress and findings that are relevant to the management of acute malnutrition. The session will be chaired by Michael Freemark, who is a professor, in fact. His 21-page CV, I'm not kidding, 21 pages, is best summed up in his professional dedication to the care of children and adolescents with endocrine disorders and diabetes. He's had a long-standing interest in the hormonal control of maternal metabolism and fetal growth, and in the endocrine aspects of obesity and malnutrition. Although Mike was a sporty child, he played basketball and softball and pool and ping pong, he was also, this is his words, okay? And this is a technical professor speaking, 21-page CV, he was overweight and shy. Not so now. This man has transformed himself, and he's an optimist at the core, and is testament to how personal change is achievable by us all. What a fabulous motivator. Over to you, Michael. This is a mic, a roving mic.
I stand before you today as a relative outsider, newcomer to the field of global malnutrition. As you heard, my research has been focused on the hormonal control of maternal metabolism and fetal growth, based in the laboratory largely, but I've also had a clinical interest in the hormonal control of food intake, fat deposition, and the complications of obesity. So nutrition is dear to my heart. And I hope to convince you today that hormones, growth factors, and cytokines play critical roles in the pathogenesis of acute malnutrition and perhaps in its therapy. But as a pediatrician, I must say that I've been inspired here by the dedication and commitment of the people in this room to children in need. And I've been impressed by how much this community has accomplished over the years. I'm also, I must admit, awestruck by the magnitude and complexity of the problem, by the challenges faced by healthcare providers and government officials at all levels, and the major gaps that remain in the fundamental understanding of the pathogenesis and treatment of the condition. For better or worse, the presentations today are not going to answer all of the lingering questions. They're not going to close all the gaps. Rather, they are going to delve more deeply, hopefully provide new insights into the roles of metabolism, metabolomics, immunology, microbiology, and pharmacotherapy in the evaluation and management of severe acute malnutrition and moderate acute malnutrition. Hopefully this is going to increase our understanding and perhaps give us a new way of looking at the problem, shedding new light on the issue, and encouraging us to seek new approaches to prevention and treatment. And so I'll begin by introducing briefly our first speaker, who's Mark Minari. Everyone here knows Mark. He's one of the world's leading figures in the field of childhood malnutrition, and I'll leave it to him.
Well, thank you, Michael, for inviting me in the session, and thanks to the organizers. Great thanks to the IEAs. We're winding down. We're approaching 72 hours now on this conference. And I'm talking to you today about the microbiome. So a few comments to start with. I mean, many of us have heard about the microbiome for 10 years. And we've heard about it in very broad strokes. And one of the keys to understand, I think, is when you hear about things in sort of grandiose promises in broad strokes, it means we don't know very much about these things. And the more we know about them, then the more grinding details, like some of the things that we've heard about already. So what I'm going to say is speculative in some ways, is futuristic, but there have been already 3 or 4 different trials that we can find where the microbiome's been altered or tried to be purposely altered in the treatment and care of malnutrition. So to take a look at that. But, okay, so the microbiome. We know that we've heard a lot about what that is. That's the commensal symbiotic collection of all microorganisms in and on our body, and really that 99% of them plus are in our gut. We've got about 80% of them in the colon and 20% of them in the ileum. But they do include a few parasites. They do include yeast, archaea, a few other kinds of organisms. So naturally, the microbiome is something unique. It's, everybody's microbiome is a little different. Sometimes people use the word fingerprint, but the deal with fingers is they all kind of work the same and they have the same function. So the print doesn't really matter so much. And this is very true of the microbiome, that it's a functioning organ that's doing something, and the names of the inhabitants of the microbiome are far, far less important than what they're doing. So what does the microbiome do? Okay, what do these germs in our gut do? Well, they take fiber, indigestible carbohydrates, protein granules, and they can break them down and turn them into usable nutrients. Sometimes they synthesize small molecules that are essential, like vitamin K. They also we shouldn't think about the microbiome as sort of like, environmental contamination. It happens, and you shouldn't think that the human gut in many ways has evolved with a set of organisms to work together to help the body and sustain the populations of these microorganisms. So they not just provide nutrients, but they're secreting molecules that are modulating the immune system. They're sort of revving it up or turning it down, telling them to be worried that an enteric infection is coming, or saying, calm down, no enteric infection is around here, by secretion of short-chain fatty acids. Detoxifying molecules. We hear about aflatoxin here. And part of that aflatoxin that people ingest doesn't get into their body because bacteria are doing something to it to detoxify it, if you will. So that's, in very broad strokes, some of the things what the microbiome does. This slide here, which I like, is on this x-axis in the first part, is the names of the organisms, if you will, in the microbiome. And you can see through some people, through a fairly homogeneous population, there's quite a difference in the names of those organisms. You can imagine this being child 1, child 2, blah, blah. But these colors here represent what the microbiome is doing. So carbohydrate metabolism, amino acid synthesis, those don't change quite so much. So, this is just another way to say that the microbiome is more similar about what it is than different. And the just the terminology where the metabolome is sort of the net synthetic, enzymatic sum of what the whole microbiome does. It changes with age, and the age effect is much more important than, say, the difference in diets or geography. This is a study that we did with many other collaborators, where kids in 3 locales, Malawi, Venezuela, and the U.S., and these axes here are something called principal coordinate 1, and they mean sort of like the characteristic that's inducing the most variation. But you can see that there's more of that. It's different in younger kids, and then about 3 becomes pretty constant. The populations will cluster by geography. And if you looked at the length of these bars, you're seeing that the small bars for the young kids are more similar to other small bars in young kids in other countries than the adult bars. So I guess this is another piece of evidence to suggest the microbiome is a functional organism. And we need to move ahead here quickly and see how that time is running out. I can imagine the microbiome, therefore, how it might be involved in malnutrition in terms of providing nutrients, food security, and either it's appropriate or inappropriate signaling with the immune system. So that's pretty much the material we've covered. We did a large twin study, and a little bit on the background of this is so. I'm at heart a clinician, and I'm not a research lab rat, but I really want to try to solve these questions and answer them at some basic level too. So I went to Malawi 20 years ago, and I've been there ever since, and I was just amazed the fact there's so many kids there with kwashiorkor, and so you start looking into what's going on with kwashiorkor. It's not protein deficiency, it's oxidative depletion. And, we tried a large, with a couple thousand kids, randomized trial of multiple antioxidants, and it didn't do anything with kwashiorkor. We looked at thousands of kids in their food intake prospectively, and then see who would develop kwashiorkor over the next 2 weeks. No, that doesn't have anything to do with food. So I started bugging a colleague of mine at Washington University, Jeff Gordon, and I said, I want you to test these bacteria in these kids. And of course, this is like 2005. When we were 3 or 4 generations of sequencers behind what we are now. And he said, I could do 1 or 2 a year. And would take a whole postdoc. So we just kept bugging him, and then the technology caught up. So we ended up doing this twin study in the late, about 5 years ago, where we had about 317 twin pairs. And it was clear to us clinically beforehand that kwashiorkor was not occurring that malnutrition occurs more likely in twins, probably just because of resource constraints, but kwashiorkor doesn't. And so among these kids, we followed for a 3-year period from as early as we could find them till they were 3 years. We had about half of them developed severe malnutrition, and only 7% of those, or 14% would be that where they happened in the same house. Okay, both twins. And we looked at those children's microbiome. We took stool samples almost every other month, and then when they were having malnutrition, at their prometry problems, we were taking stool samples very frequently. And in this picture here, what you should look at is here's 2 twins, and they're both well nourished, and they both have very similar microbiomes. The pattern on that, among that. But here's 2 twins. Okay, these twins, right? I mean, they live in the same house, they're subject to the same environment, they share at least half of the same genes. They're pretty similar kind of kids. And one of them's got kwashiorkor, and they've got a very different pattern of bacteria in their microbiome. And these twins as a population were showing the same kind of age effect. And Jeff does some very fancy stuff with mice that don't have germs, and we can transplant the microbiome into these mice, and we can grow it up and see what happens. And lo and behold, if you give one of these mice a good microbiome and a horrible diet, and a diet just markedly lacking in micronutrients and energy, some energy restriction, they don't develop malnutrition. But if they had this bad microbiome, they do. And these are genetically the same mice. So another sort of clue that the microbiome is playing some role in the pathogenesis of kwashiorkor. Okay. If we look ahead to a couple of other studies related to nutrition and the microbiome, we have this one, and I think this one is probably something a lot of people might be familiar with in this audience, a school-age children's study where iron supplementation was given to kids in Côte d'Ivoire because their hemoglobins were low in general as a population. So let's boost it up, let's see what happens, okay? And what happened, of course, not shown on this slide, is there wasn't actually any change in their hemoglobin after they got iron supplementation with iron sulfate for 6 months. But there was some changes in the bacteria in their gut. And so that's depicted in these pictures. So these are three different genera of bacteria. And you can see that there was no change in this one pretty much. You want to compare this bar to that bar, or the white ones to the white ones. This one, there was some increase in this lactobacillus. But the Enterobacter in the iron group is the dark, the shaded bars, went up. And this is considered to be a pro-inflammatory bacteria, one that makes the wrong kind of short-chain fatty acids to constantly inflame and irritate and make this gut enteropathic. And then if you measure the colon irritation with calprotectin, you see that that's high too. So what this is, I wouldn't say this is, it was a horrible thing, giving these kids iron sulfate for 6 months, but it's a kind of a cautionary tale in the sense that their intention, of course, was to help these kids with a micronutrient deficiency in their anemia. We didn't do that, but in general, nobody's thinking about these bacteria in the gut, or there's not enough awareness of what the bacteria in the gut are doing, that they're going to be responding to these nutrients too. So that is a story from Côte d'Ivoire, and then a story from a colleague in Malawi, and I don't see him in the audience. Marco Carrick, is he here? Isn't it? So he's a little ahead of his time. He's 7 years ago trying a probiotic and a prebiotic intervention for the treatment of SAM. So he had two different groups of kids in a large urban hospital. Unfortunately, half of those kids had HIV, and that was probably their sort of primary clinical problem. This table is totally unfair to show to you because it doesn't show you a damn thing. But the children received either standard RUTF or one which had a combination of 4 prebiotics and 4 probiotics in there. And although it was a negative trial, there was no particular benefit to seeing. Their hope was that the gut would heal faster in this trial, but didn't heal faster. At least it didn't show up clinically as a benefit to those kids. It just point out that some people in this community have been thinking and trying things to affect the microbiome for about 5 years or so now. Well, so where does this leave us as we look ahead? I think as nutritionists we often feel like there's so many interactions and it's hard to keep all this straight, and I think the biggest challenge in the nutrition community and the nutrition research community is the deal with our field is it's all about interactions. So it's not just about, a mass balance where we need to put in so much zinc and then we put that in and that's good. And that exists in kind of in a vacuum from everything else that's going on. And then we throw on top of that, we say, well, we've got these environmental effects in terms of exposures to inflammatory stimuli or pathogens. And now we're going to throw in something else, but we're not. It's life. We're not in control of what the way life is on the planet. But I want to. We have also done a trial. I didn't show you some slides from where we fed some children some resistant starch, mixed into their food, and it was there, and we watched them. It was very high compliance. We gave it to them. We saw them, and we saw a change in the names of the bacteria in the microbiome, and a little bit of change in the metabolome. So whereas in the iron study from Côte d'Ivoire, there was a more pronounced change in the metabolome of that group of children. So I think that we can do better at caring for these children by including this some way in our equations. How would we do that? Well, when we do a trial, maybe it's appropriate many times to be assessing part of the something about the microbiome. If you know you're doing a well-controlled trial, it requires a stool sample. It's not really something that's very tricky. And then obviously the lab work is something that's hardly available anywhere in the developing world. A couple of opinions, notes about the microbiome for people who are hearing this and wondering. In general, like all attempts to change the microbiome by adding other bacteria to the system really don't work. So, so the idea of probiotics and stuff, when we can't find that's really changing the bacteria. You can sort of see a little bit of it, and then the day you stop, it's gone. But what determines these populations of bacteria is what you feed them. And what you feed them is, the way our gut is set up, is to suck out all the nutrients it can in a pretty microbe-free environment in the upper intestine, and then the bacteria get to do their work. So the fiber or undigestible carbohydrate and this kind of stuff, this is what's going to determine the microbiome. And perhaps when Marco did that trial, he tried 4 different prebiotics at once. There wasn't, any kind of evidence-based rationale behind what he tried. He tried really low doses. If somebody said, why didn't that work? I'd say, well, it wasn't because the microbiome isn't necessarily important in that. But, you tried lots of different prebiotics together, and you didn't try them in very, very big doses. There's certainly a lot of work to do, but I think that's about what the message I want to leave you with is we've been a growing appreciation in the last 20 years of the microbial community within. It's playing a huge role in nutrition. I can tell you about different mouse studies where the microbiome is making these mice obese, even though they're eating the very same diet as other mice, and the twin studies in the U.S. were showing an association between microbiome and obesity, and then we see problems from the developing world like kwashiorkor, where somebody says, well, what was the meaning of that paper? And I'd say, well, it seems to me you have to have a bad diet and a bad microbiome to get kwashiorkor. And maybe if you just have a bad diet, you just get thin and you just get wasted. Something like that. But something we certainly didn't anticipate. I know that's about all I think I want to say right now. But we'd be happy to answer questions either at the end of the time or is it now I'm supposed to? Well, yeah, okay.
Thank you very much, Mark. We'll have a Q&A session at the end. And so we'll proceed with our second speaker, who is Dr. J Barclay, who is as well known to you as Mark, perhaps. Jay is an infectious disease specialist who's worked in Africa for the past 20 or more years. He's been very interested in... While we're loading, I want to thank the organizers of this incredibly interesting conference. I've learned an enormous amount, and I really appreciate the opportunity to speak with you today. I want to tell you about the results of a recent study that I hope will provide some new perspectives on the pathogenesis of severe acute malnutrition and something about the factors that may predispose to death. We used an approach called metabolomic analysis. This allowed us, through tandem mass spectrometry and centralized microassays, to provide a comprehensive profile of the metabolic status of patients at presentation and to characterize in less than 1 ml of plasma more than 100 fatty acid and amino acid metabolites and a panoply of hormones, cytokines, growth factors, and cytokines during nutritional recovery. We hypothesized that hormonal and metabolic factors at baseline might predict mortality during treatment. The study was conducted at the nutrition unit at Malago Hospital in Kampala, Uganda. It was a relatively small study of 75 infants and young children ages 6 months to 5 years. They were severely malnourished. Weight for height C-score was minus 4.2. Approximately 1/4 were HIV infected. 1 of 10 had malaria. Approximately 60% were edematous, and 1 of 8 children died during the first 2 weeks of inpatient admission. The patients were treated with F75 formula with micronutrients and then moved on to F100 after approximately 2 weeks of inpatient admission. Then they were moved on to RUTF, and as you can see, the mean weight for height C-score rose from minus 4.2 to minus 1.75 standard deviations. Blood samples were obtained at baseline, 2 weeks after inpatient admission, and 4 to 10 weeks after onset of ready-to-use therapeutic food therapy. Using our approach of tandem mass spectrometry and metabolic profiling, we found that children at baseline had clear-cut demonstration of the central role of fatty acid metabolism in the adaptation to malnutrition. As you can see at baseline, there were high levels of non-esterified fatty acids, ketones, and even-chain acyl carnitines, represented here by C2, which is acetyl carnitine, indicating high levels of lipolysis and fatty acid oxidation. In contrast, there were low levels of albumin, amino acids, and C3 carnitine, which is a byproduct of branched-chain amino acid metabolism. Triglyceride and ALT levels were high, as can be seen with fatty liver. Phosphorus levels were low, but as you can see, blood glucose, lactate, and creatinine were maintained in the normal range. These metabolic changes were associated with striking changes in hormone growth factors and cytokines. At baseline, there were very low levels of insulin, insulin-like growth factor 1, and 2 adipocytokines, adiponectin and leptin. In contrast, there were very strikingly high levels of ghrelin, growth hormone, cortisol, interleukin-6, and 2 intestinal hormones called GLP-1 and peptide YY. Now, these high levels of GLP-1 and PYY are a bit counterintuitive because these are thought to be peptides that inhibit food intake, which in a sense would make sense in a child who's acutely malnourished. But the levels of leptin, adiponectin, and ghrelin likely make sense in context. Leptin and adiponectin are produced by white adipose tissue. Leptin stimulates energy expenditure through induction of brown adipose tissue thermogenesis, and it reduces food intake. So low levels of leptin at baseline would be expected to reduce energy expenditure, thereby conserving energy, and to increase food intake when nutrients become available. Adiponectin is an insulin sensitizer, and so low levels of adiponectin would be expected to reduce insulin sensitivity and thereby assist in sparing glucose and preventing hypoglycemia in the acutely malnourished state. Ghrelin is produced by the stomach. It stimulates food intake and growth hormone production, and so high levels of ghrelin would be expected to increase food intake, thereby complementing the effect of hypoleptinemia and to stimulate growth hormone secretion. And so if we integrate the metabolic response to malnutrition, we find that active lipolysis is likely to liberate glycerol, which is used for hepatic glucose production, or HGP, as well as non-esterified fatty acids, which are used for fatty acid oxidation, or FAO. There is diminished glucose uptake and oxidation, as well as decreases in protein synthesis and proteolysis in skeletal muscle. We know this from this work and from the work of others, including Mark Minari. Bone growth during the acute phase of the illness is markedly reduced, in large part because of a severe decline in IGF-1 levels and a rise in the cortisol levels. These metabolic changes are driven by striking changes in hormones, growth factors, and cytokines. The ghrelin-induced rise in growth hormone, in concert in those who are infected with a surge of epinephrine, induces lipolysis in patients who are insulin deficient. So the combination of hypoinsulinemia and increases in growth hormone are a drive for lipolytic breakdown of fat. Of course, that provides the essential energy source for cardiopulmonary function during acute malnutrition. Interestingly, during the acute phase, the effects of growth hormone on IGF-1 are attenuated or blocked. Growth hormone is not capable of stimulating growth factor production under conditions of malnutrition. So IGF-1 levels fall despite the high levels of growth hormone. But the effects of growth hormone on skeletal muscle are IGF-1 independent. And so they are maintained during malnutrition. The high levels of growth hormone act as insulin antagonists, suppress glucose uptake and oxidation, thereby sparing glucose for critical organs like brain, red blood cells, and kidney. And growth hormone suppresses proteolysis from skeletal muscle, and that serves to preserve muscle mass, particularly in those who are edematous. Now, during recovery, following formula feeding and then RUTF, there are dramatic increases in serum albumin, amino acids, and C3 acylcarnitine. Again, this is a byproduct of branched-chain amino acid metabolism. At the same time, there are striking reductions in non-esterified fatty acids, ketones, and acetylcarnitine. In other words, there is an increase in protein synthesis, amino acid utilization, and a striking decline in fatty acid in lipolysis and fatty acid oxidation. This also is driven by striking changes in hormone and growth factor expression during recovery from malnutrition. As you can see, during the inpatient and outpatient periods, there are striking increases in insulin-like growth factor 1, and leptin, and conversely, striking reductions in ghrelin, growth hormone, and cortisol. And surprisingly, again, decreases in the gastrointestinal hormones thought to be anorexigenic, GLP-1 and PYY. So, integrating our thoughts about the recovery from malnutrition, we postulate that malnutrition is associated with lipogenesis, that's fat buildup, glycogen synthesis in the liver, and protein synthesis and increased amino acid utilization in skeletal muscle. There is gradual increase in bone growth as a result of an increase in IGF-1 production, but as we've heard from many people today, that increase in bone growth may be delayed, attenuated, and it may never occur at all. So this is really interesting to me as an endocrinologist. Again, this recovery from malnutrition driven by changes in hormones, particularly the rise in insulin, the fall in cortisol, which induce a decline in hepatic glucose production, and recovery of the ability of growth hormone to induce IGF-1 production, and that's going to enhance bone growth, at least to some extent. The leptin levels rise with the accumulation of body fat, and there is an increase in adiponectin, and that suggests that recovery from malnutrition is associated with an increase in insulin sensitivity, at least before the child becomes obese in the long term. Now, a major goal of the study was to determine whether there were factors at baseline that predicted mortality during the inpatient treatment. And in a univariate analysis, we found that there were a number of factors that predicted mortality. They had included HIV infection itself, a decrease in weight Z-score, a decrease in mid-upper arm circumference, and a decrease in adiponectin levels, and an increase, conversely, in peptide YY and 3 cytokines, interleukin-2, interleukin-6, and TNF-alpha. But the most powerful predictor of mortality, at least in our study, more powerful than weight Z or MUAC, was the level of leptin. That is, hypoleptinemia was a stronger predictor of mortality than any of the other biochemical factors that we measured in our study. Now, this is really interesting because leptin is not simply a measure of the adequacy of adipose tissue stores. It is a critical regulator of immune function. And so low levels of leptin not only would affect energy expenditure or food intake, but they're also going to create an acquired secondary functional immune deficiency. Among the patients who survived the study, the mean level of leptin was 280 picograms per ml. Among those who died, the mean level of leptin was only 7 picograms per ml. And among those patients who had leptin levels less than 35 picograms per ml, all of the patients died. Among the patients who died, all had leptin levels less than 35 picograms per ml. Among those who survived, 84% had leptin levels above 35 picograms per ml. And in a multivariate regression analysis, both leptin and HIV were significant predictors of mortality, while weight for height Z-score and high molecular weight adiponectin were not. Now, we've heard a great deal here, but not enough, about the effects of low birth weight on subsequent risk for malnutrition and for long-term mortality. And it may be, therefore, of considerable interest that the biochemical phenotype of SGA children at the time of birth is quite similar to the biochemical phenotype of severely malnourished children. There are low levels of insulin, IGF-1, leptin, and adiponectin. Low birth weight children are insulin resistant. Conversely, the levels of ghrelin and cortisol are elevated. This raises lots of questions and certainly warrants additional investigation because it is clear from what I've heard here during this conference that low birth weight is a critical factor in long-term morbidity and mortality. So, in conclusion, fatty acid oxidation provides the primary energy source for gluconeogenesis and cardiopulmonary function in children with severe acute malnutrition. Muscle proteolysis and amino acid utilization are suppressed in severe malnutrition unless the children are infected. We know that from previous studies, but certainly true if patients are edematous. That the changes in fatty acid and amino acid metabolism are driven by changes in hormones and growth factors. I've described some of those today to you: leptin, growth hormone, insulin, cortisol, and IGF-1. But the roles of gastrointestinal hormones are a bit paradoxical. We don't understand their roles right now, and it probably has something to do with the enteropathy and the microbiome, but that clearly needs more study. Malnourished patients, like SGA patients, are hypoadiponectinemic. They have low levels of adiponectin and functionally likely to be insulin resistant. And that catabolic state is reversed within 2 weeks of inpatient formula feeding. Finally, the major biochemical factor predicting mortality was a low level of leptin. Now, it's interesting that we found that neither non-esterified fatty acids, a marker of lipolysis, nor ketones, another marker of fatty acid oxidation, were predictors of mortality. So we struggled with that one. And here's how I try to interpret it. I think that hypoleptinemic patients can probably mobilize and oxidize their fatty acids acutely during the immediate phase of the acute illness, but they likely deplete their adipose tissue reserves very rapidly. And that lack of adipose tissue reserve keeps them from being able to sustain energy production, perhaps during the first 2 weeks, but even perhaps, Jay, longer over time. And until that full complement of adipose tissue reserve is fully reestablished, that child is probably at risk for infection and lack of adaptation to infection. Now, low levels of leptin might also have other ways of reducing viability, and the major way I can think of is that it may impede immune function. That's because leptin activates every part of the immune system, the T-cell repertoire, proliferation, activation, all induced by leptin. So it's possible that the hypoleptinemia makes that child places that child at higher risk for death. To be honest with you, we don't really know why SGA children are at higher risk of death. And it's possible that the hypoleptinemia of SGA has something to do with their long-term risk of death. Now, what would a conference be without some wild speculation? And so I'm going to serve that purpose. It's been such a restrained and quiet conference, so I'm going to try to add a little heat to it. First, metabolic and hormonal profiling through metabolomics, tandem mass spectrometry, can provide a comprehensive analysis of the adaptations to childhood malnutrition and treatment. I think it was Andre who mentioned it, or perhaps others, that this could certainly be the case for other nutritional deficiency states: anorexia nervosa, lipodystrophy, chronic HIV infections, intrauterine growth retardation. All are susceptible to more in-depth metabolic analysis that might give us new insights into their long-term survival. Secondly, we've heard a lot about mild and moderate malnutrition and the fact that it's not so easy to identify in its early stages. Well, leptin as a marker of adipose tissue reserve, perhaps in the future leptin might serve as a marker of preclinical, that is, pre-observable, identifiable malnutrition on the ground. Much would have to be done before that were achieved. But likewise, as you know, weight Z, weight for height Z, even MUAC can be very difficult or sometimes impossible to interpret in patients who are edematous. In our study, hypoleptinemia predicted mortality in edematous as well as non-edematous patients. So measurement of leptin might be a way of identifying those children who are at highest risk of death. We've heard a lot about the risk of infection. I've said to you that leptin is a modulator of immune function and therefore could play a critical role in the risk of death from infectious disease. And then finally, leptin has been used to treat children and adults with lipodystrophy very effectively. Could leptin treatment, at some point in the far distant future, serve as an adjunct, not as the primary treatment, but as an adjunct for treatment of children who are severely malnourished? I want to thank the people with whom I collaborated, Elizabeth Kibaneka and Tony Kiimba at the Malago Nutrition Unit, my colleagues at the Department of Pediatrics at Duke University Medical Center and the Duke Molecular Physiology Institute, and the Duke Global Health Institute. We had support for this study from PepsiCo Global R&D, John St. Peter, and from the Genentech Foundation. Thank you so much. I've really appreciated and enjoyed the time. And now I will run back and try to moderate the question and answer session.
Shall I do that and you can concentrate?
Please.
Yeah?
Okay.
I think you've done enough, actually. So I'll be the bully, and you can concentrate on providing answers, because I have no idea what he's talking about. Questions over here and there. Jose?
Yes, Madam President.
Is there anybody who can translate? Is Andre in the room?
Yes, I need translation.
Okay. I am in the room. Yes.
Okay, thank you very much. Ma question s'adresse au professeur Freemark. Oui. Je dois dire que je suis très impressionné par les résultats de cette recherche sur la leptine. Mais évidemment, dans notre contexte, j'ai des préoccupations. La préoccupation, c'est d'abord le coût du dosage de la leptine. En termes pratiques, est-ce que c'est quelque chose qu'on peut prendre en compte dans le contexte des pays sous-développés où on a justement ces nombreux cas de malnutrition? Deuxième sous-question, est-ce que vous avez fait des analyses croisées entre la leptine comme indicateur de mortalité et la mesure du périmètre brachial? Si c'est le cas, quels ont été vos résultats? Dernière question, qui n'a pas été évoquée. Que pensez-vous de l'apolipoprotéine A1 comme marqueur de l'état nutritionnel et facteur de risque de mortalité en cas de malnutrition? Merci beaucoup.
Shall I translate?
Translation, please. Translation, please.
I would like to translate and put in some of my remarks as well. This is the privilege of the senior translators. So the question, the comment that he made is that he was very impressed by your work on leptin. He has a worry, however, he has a question about the cost. And his main question is this analysis possible in a country? Then he had another question as well about the link between MUAC and leptin. Did you study any correlation between the two? And here I will put on my own remark. Did you differentiate did you have any data about skin fold thickness? And as well, do you have different data about skin fold thickness at the triceps level and at the subscapular level? Because I was very impressed by the remark which was made by Jonathan 2 days ago, where he mentioned that apparently these two kinds of skin folds don't have the same link with the immune system and the risk of death. And final question, this is from our colleague again, but not mine. What do you think of the role of apolipoprotein A1 as a marker of mortality?
Actually, I just think these questions are so technical. Can we just take them one by one? Because I think we'll lose the thread. Yeah.
Thank you for your questions. At the present time, of course, the leptin assay is not only costly, but cumbersome and not feasible in the current setting. However, there are potential ways to address that, and my colleagues and I are trying to develop a more feasible approach to using leptin clinically. As far as the relationship between mid-upper arm circumference and leptin levels, there wasn't as strong a correlation as there was with wafer height C-score. And thirdly, we have not, I don't have any opinion at all about the relationship between ApoA1 and mortality. Oh, I'm sorry. About the skin fold thickness, we did not do it. It's very interesting. We just didn't do it.
Dr. Tulukta?
Yes, questions for both Dr. Barclay and Professor Freemark. Did you look at the relationship of breastfeeding to these mortality figures that you've both shown?
Yes, we did. We looked at a number of factors. So obviously breastfeeding is related to age, but when we analysed breastfeeding within the younger age groups, it didn't have any association with mortality. I'll just add to that about 20% of the younger age groups were born either prematurely or small for gestational age, and in fact that also didn't have an association with mortality. In the models for mortality, in fact the MUAC and age actually just completely absorb pretty much all other potential predictors.
And we didn't look at this specifically. We encouraged all women who were capable of breastfeeding the children at the appropriate age to breastfeed, so this was not isolated as a variable.
Professor Roy?
Yes, Mark, great talk. On the issue of low leptin, did you also assess leptin sensitivity? Because you might have lower leptin, but the overall effect might be increased sensitivity, just like with insulin.
Yeah.
It's an excellent point, and by the way, extremely difficult to assess. There is a circulating leptin binding protein, which we did not measure, but even that per se doesn't test leptin sensitivity directly. But your point is clearly well taken.
There's a lady there at the front with flowers on.
Nelly Zabaleta from Peru. I have three short questions. For the first presenters, what do you think that make the difference in the microbiome? Because we observe that even in the same family, even siblings, they are eating from the same family pot, and you note that some of them make changes in malnutrition, but the others not, and they have different microbiome pattern. What do you think? This makes that difference. For the second presenter, I'm asking a short question about the antibiotic prophylaxis. Is that during the 6 months treatment with antibiotics, would you make a difference also in the lactobacillus and other good bacteria? So that would, which consequences do you think will be in your results? And the last question about the leptin, which I found it very interesting, is that it is quite interesting how does it fit the early life programming, because all these changes in hormones, do you think that these children will change these hormone responses for the rest of their life and will be condemned to high risk of obesity and overweight?
Yeah, in terms of the microbiome, the change you see in the microbiome was not present for a long period of time, but we're taking so many stool samples, it was present for a month or two before the onset of the edema, the clinical problem. And to find two twins with dissimilar microbiomes is a really unusual thing, because the twins living in the same house, same age, all that bit, have got very, very similar microbiomes.
We expect that the cotrimoxazole prophylaxis would have had a fairly major effect on the microbiome, and we've collected samples for that. We haven't analysed them yet. If somebody wants to give me some money, then I'll be happy to analyse them.
Thanks for your question about the long-term risks of obesity and type 2 diabetes and other chronic cardiovascular complications. This actually is quite an interesting question. First of all, it turns out that those malnourished or SGA children who are at risk for long-term obesity and type 2 diabetes are those who have rapid weight gain sometime between ages 2 and 10 years of life. That is excessively rapid catch-up growth from a background of relative malnutrition, growth retardation. It's one possible theory is that the hypoleptinemia in those SGA children actually drives them to eat faster and put on weight more quickly. And so it's possible that it does have some long-term programming effect. But an interesting study many years ago showed that leptin treatment of newborn growth-restricted mice or rats was able to prevent subsequent excessive weight gain at the older age level. In other words, it suggested that intervening with leptin, normalizing the leptin levels, was able to nip that process in the bud, prevent it from overexpressing itself. And so, no, we are never doomed. But this is obviously a very difficult problem. As regards growth, we don't really understand that process at all. And as an endocrinologist, I can tell you that most children that we see who have growth failure secondary to nutritional disorders have a secondary growth failure that recovers when weight recovers. So what you are seeing in your malnourished population is different than the standard failure to thrive that we see all of the time in the clinic in every country. So this process, this pathogenesis of growth failure is different. And I don't understand it, but it's really fascinating. I do wonder about the long-term effects of some enteropathy. I do worry about the effects of growth restriction very early in life that keeps those children from subsequently catching up in linear growth. And so we have a lot to learn in that area. I think it's really important.
Okay, there's a gentleman there on the end. Yeah, you, sir.
Thank you very much for this educating session, actually. A couple of questions. Number one, related to the dietary fibers. You talked about different type of prebiotics. Would soluble, fermentable prebiotics make a difference or any impact on the different, what you can say, friendly bacteria or the probiotics? This is one question. Shall I give them one by one, or?
You can have one more, and then that's no more from you.
Okay. The second question is related to the leptin. How far are we clear about the leptin carriers, the protein? I mean, because this is very influential in the whole circulation as well as the expression. Okay.
Could you repeat that last question? Because
the leptin carrier proteins, because there are different postulations that they're saying there might be more than one carrier. Okay, so this is very.
Sure. For sure, the only way I would say that to change the microbiome beyond the normal changes you're going to see with age and diet, children growing up, is with some kind of prebiotic. I don't know. There's no evidence to suggest what kind of prebiotic could be helpful, if any.
Soluble or insoluble. I mean, because it makes a hell of a difference whether it is water-soluble or insoluble.
Yeah.
Because if it is soluble, you can have a lot of short-chain fatty acids very quickly.
Yeah. I don't know any evidence to suggest either one, no.
You asked about the leptin-binding proteins, which are both soluble and, of course, expressed on many tissues. There are leptin receptors. Again, a fruitful area for investigation. Really don't know much about leptin sensitivity in malnutrition. Might be important.
Okay, I'm going to go over here to Josephine, and then I'm going to go to this lady, and then to Andre.
Yeah,
or you don't need it.
Yeah, my question is to... Sorry, can I? Yeah, okay. My question is to Jaya. The mortality figures that you presented is kind of quite... I think it was 30% or so. So I was wondering, is it as a percentage of those who got out of the program, or is it...
Speak into the mic, Josephine. We can't hear
sorry.
you.
Jaya, my question is the mortality figure that you presented. Is it around 30% or so amongst, I thought it was a bit high, so I was wondering, is it as a percentage of the exit or the total children who are in the program? And secondly, I have just a quick one. Since it's a prophylaxis antibiotic, does that, if it was for some, if it was more treatment, would that make a difference in terms of, I don't know. I just wanted to find out.
Yeah. Firstly, I mean, the proportion for mortality was of those who were enrolled in the trial. So to be enrolled in the trial, they had to be severely malnourished and admitted to hospital. And in that highest mortality group, under 6 months as well. I think there's a particular issue with the under 6 months group, which is that we haven't really worked out well what to do with them in hospital. And even though they were followed in clinic, followed in the nutrition program, they were, in a lot of cases, mothers didn't have a good feeding option, and the services weren't able to provide a good feeding option after discharge. So although we were shocked to see the mortality, I think we can begin to explain it, but it does point to a crisis, I think, especially now we've demonstrated it across 4 sites in different places. I don't know. I mean, you could say we could use a different antibiotic or a different dose or a different strategy, and you may be right. It may be that some subgroups had benefit, but those weren't questions we asked in the study. Maybe giving intermittent treatment courses might be better. We don't know.
This lady here on the end of the table, yeah.
Thank you very much. I'm called Hanifa. I actually work at the unit where Michael was, but at the time you exited, then I was also joining. I just want you to help me clarify if you controlled for other feeds. When you describe the story, it looks at WHO prescribed feeds, F75, F100, and RUTF. However, that is not the actual practice because we are faced with diarrhea either when we start the feeds or when we change the feeds. Is there any fluctuation when a child is switched off the feeds, or did you remove them, or what happened to that? It's with
this is to Mark.
The study in Mlago. Okay, I don't know. Lago Hospital.
You were referring to diarrhea?
Okay. I'm saying that the changes we see, they seem to be telling the story as though children were on the feeds the way WHO prescribes them, that start with F75, when you stabilize, go to F100, then RUTF, and they go home. However, the clinical actual practice is that in the event that they have diarrhea, there is a fear when we see a child deteriorating to shock and then attempt to change feeds to otherwise what WHO describes. So I wanted to find out if you removed such children so that we know that your leptin and all the other metabolites and biochemical changes were for those children that were on F75 and F100, or if you left all the children in that basket and looked at them together. Because definitely there is a consequence of another feed that is not F75 and not F100. And you are aware of that we give them to these children.
Yes, your point is well taken. We analyzed all of the patients at baseline at the time of admission to the hospital. The ones who died didn't have follow-up leptin levels, and so we compared those leptin levels at baseline across all of the patients. Some of them had diarrhea. I simplified the presentation by listing F75 and F100. Some of the patients were managed acutely at the time of the of present. We did not eliminate those patients.
Andre?
Can I just make a comment on that? I think a lot of people are becoming aware that there are problems with F75 and F100, and a lot of health workers tell me that they have a problem with children getting diarrhea once they start F75, and then they get diarrhea once they start F100. We're just about to do a trial between both in Kenya and in Malawi with a modified formulation of F75 initially, where we've removed all of the lactose and reduced the carbohydrate content to try and get over the problems of diarrhea associated with those feeds.
Andre?
Thank you. Actually, my question is related to Jay's comment. I mean, you treated this children according to WHO protocol, and the WHO protocol is to start with F75, which is a very high carbohydrate, very low fat diet. Personally, despite years of contact with WHO, I never understood the rationale of this approach. Because from what you showed, these children, they are burning fat, they live on fat, and then suddenly they are put on, and once they are admitted on a totally different diet. And I would like to have your opinion on this practice.
Well, as I said, I am a relative newcomer to this field, and I understand that these formulas have been developed by people who have much more experience than I, and so I really don't want to take a real strong position on this issue. Yes, I appreciate that, but that's going even too far for me, and so I don't really have a strong feeling about that.
There's a lady in the back, yeah.
Hi, my name's Hattie Barthorpe from Goal. Two very quick questions. One to Jay. If your study had been successful, would you have thought would there be any issues surrounding antibiotic resistance over a 6-month period? And then just a quickie to Mark. Re or pre-probiotics that you were discussing around Marco's study, would the routes of introduction have made a difference? So I presume Marco was introducing them orally. If they'd been directly introduced into the large intestine, would that have made a significant difference?
Yeah, I think the antibiotic resistance question is a really good question. In fact, we did a whole series of parallel studies looking at nasal swabs, rectal swabs, and culturing samples from children when they got sick, exactly for that reason. In case it was successful, we'd be able to advise on antimicrobial prophylaxis. And to summarise the results of those, the proportion of bacteria that you detect which are resistant is greater in the arm who got cotrimoxazole, but the absolute number is much lower. So the actual number of resistant bugs you get was actually lower in the cotrimoxazole arm. And that's the same as what's been seen in the HIV trials, where it's actually, because you get less infections, although more of them are resistant, the overall picture is less resistant infections. Is that clear?
So there is an emerging practice of with people with severe colitis getting feces via enema, but that is not something that I think is in the cards for treating malnutrition, because we've got such a terribly leaky gut, to putting other kinds of germs in there. And prebiotics, you need to be fed from above. I mean, that's the deal with them. You can't push them up there high enough. And to say something about what you just asked Jay about, the absolute number of children that would, say, qualify for, in the world or in Kenya or someplace that Jay's talking about isn't very many. Kids who were treated for SAM and successfully recovered and this and that. So it also treated only in the hospital. So I think that we could think of that as a targeted intervention if it had worked, rather than like all kids or whatever.
Okay, Dr. Tamid?
Jay, I wonder whether this antimicrobial resistance has any impact on this impact on the effects that you received, because cotrimoxazole happens to be a almost useless antibiotic in our part of the world.
Yeah, I agree. And in fact, we knew at the beginning of the trial that amongst invasive bacterial disease isolates that we had, that the majority were resistant to cotrimoxazole. We weren't put off by that because the studies in HIV were done in the same context. They knew that they knew that the bacteria were resistant. And I think in HIV it was argued that the conditions required to establish an infection are quite sort of sensitive, and they have to be loaded on the side of the bacteria rather than on the side of the host, and that the resistance levels which you normally use in terms of treating infections don't apply to prophylaxis. That was the explanation given in HIV, and I believed that explanation. Now I'm obviously not quite so sure. But the fact that it was so protective in HIV against pneumonia, against diarrhea, really led us to this being the only choice, as it was the first choice, if you like, for malnutrition.
Okay, gentleman at the back.
Hi, morning. My name is Marvin Reed from TMRU in Jamaica. I just have a few comments, a question, and perhaps an answer. The first thing is that in your data on your metabolomics study, I didn't see the sense where you had divided your outcomes based on whether or not there was edema or not. And it's fairly well accepted, certainly from our group, that there's clear metabolic differences between individuals who are clearly marasmic versus individuals who are kwashiorkor. The other point I just want to make fairly quickly is that despite the fancy name and stuff, basically what you are studying is steady-state concentrations. And those of us who are into the kinetic fields recognizes that you can achieve a steady state by different mechanisms. And I'll just allude to the fact that in your presentation, you were making some inference about albumin, which we think is incorrect. And the last thing is about the basis of the F75. Certainly from the 70s, we have demonstrated that the ability of kwashiorkor children, which was at the time the major source of mortality, they have an inability, especially in the malnourished state, to do fat oxidation. And so it was thought that perhaps the best way to replete them at that time was to reduce their fat intake.
Thanks for your question. We did analyze the relationship between edema and the various outcome measures and found no relationship between edema and mortality, but did note that those who were edematous had lower levels of albumin and total protein, as you would expect. Also higher levels of ALT and GGT, so more prone to fatty liver, higher levels of stool fat as well. But neither age nor HIV nor mortality were associated with edema. I'm not sure I understood clearly your question about fatty acid oxidation.
The issue with the fatty acid oxidation was actually a response to the question that was posed to you, which asks why F75 is relatively low in fat and high in carbohydrates. And I was saying that clearly from in the 70s moving forward, we have demonstrated that in the acute stage, fatty acid oxidation, especially in edematous children, is relatively low. And therefore it would not make sense to load them up with fat in that stage of the day.
That's really interesting. It's just not consistent with what we found with the increases in non-esterified fatty acids and ketone bodies and C2-carnitine.
Can I have a talk afterwards?
Okay.
Okay, Kim?
Yes, I was very fascinated by the leptin results Michael provided. Do you know if the rate of increase in leptin is modifying the risk? And do you know anything about what nutrients could influence such an increase? There's a lot of data on IGF-1, on how different foods can increase IGF-1. Do we know anything about leptin in that relation?
First, a major limitation of our study, and I think this gentleman pointed out, is that we didn't examine the kinetics of the changes we saw, largely because we were limited by the availability of blood and the expense of the studies. But this is a really important issue, and it could, in a sense, or could effectively be addressed more clearly if one had a portable, rapid assay for leptin and other biochemical measures, and that's something that we're interested in working. As far as specifically what nutrients regulate leptin production, secretion, this is not particularly clear. We know that fasting markedly reduces leptin levels normally in non-malnourished patients, but the specific macronutrient regulation of leptin is not really well defined. We do know that it is regulated by fat and carbohydrate, as is ghrelin, by the way, and adiponectin. So, but to really delineate it clearly, and particularly in malnourished children, nowhere near that kind of level of sensitivity.
Okay, and our last question to Alan.
Thank you very much. Jay, could I just ask you to comment upon the extent to which hemoglobinopathies might play a role in their high levels of infant mortality?
So hemoglobinopathy is the commonest hemoglobinopathy, which is a major problem in Kenya, is sickle cell disease. We had about 3% of participants at baseline who we knew had sickle cell disease, and we had about another 2 or 3% who we diagnosed with sickle cell disease during the study. It's interesting that you've picked up on that, because the slide I showed where there was an effect in the group with other infections, actually that included quite a few patients with sickle cell disease. And so it's possible that some of the vulnerability to infection is because of genetic factors, and sickle cell is just one example of a genetic immunodeficiency, if you like. But it's also a possible, I had actually thought of sickle cell as a possible target for a similar kind of study.
Lola is telling me that it's time to wrap up, and I've really enjoyed Mark's and Jay's talks today. I have gleaned that the microbiome depends on a number of factors that Mark actually didn't mention today, but they include whether you're breast or formula fed, or how you're delivered, but particularly, as you mentioned, the nature of the diet, that the microbiome acts synergistically with nutritional deprivation to increase mortality in ways that at least I don't fully understand. And it remains unclear to me, maybe Mark could clarify this in subsequent discussions, about whether the changes in microbiome are a consequence of the changes, the nutritional deficiencies, or whether they're truly, in part, independent of them. Jay's talk, in a way, is more interesting by virtue of the fact that there was a negative response than a positive response. It means that we have to look more deeply into the causes of morbidity and mortality, and they appear to be very complicated. So it's stunning to me how high the rates of mortality are post-treatment, and so therefore our life-saving efforts only go so far, and clearly we need to do more. So thanks everyone again. It's been a wonderful discussion.
And thanks to Mike for wonderful chairing.